Ethical Dilemma Regarding the Elderly and Code Status by Brittany Wills. My ethical dilemma paper is going to be about the elderly and their code status, full code or DNR. This is actually something that I have witnessed in my own healthcare experience over several years working in long-term care. The dilemma is about families who choose to have their loved one a full code regardless of their age or health issues. I think sometimes we that work in healthcare may feel that it's cruel to have our elderly patients' status as full code, especially if they're very elderly or if they have chronic illness. Those of us who knows what goes into saving someone's life probably have very mixed feelings and difference of opinions than say that of a son or daughter. I feel that this comes down to the grieving process. Some individuals may feel guilt that they are unable to do anything else for their loved one, and this is the last thing that they have control over. This is the last chance that they are able to do something for their parent or close loved one. I also feel that we as humans are selfish sometimes. We want our parents to be here forever, for us, not for them. Emotions take over and the quality of life is sometimes overlooked. CPR can only be called successful if patients survive and their quality of life is acceptable. Neurological impairments that are caused by cardiac arrest can be a threat to this. Studies show that more than half of older hospitalized patients who are revived by CPR die before they are discharged from the hospital. As I was talking before, the grief process is a lot to consider when dealing with this ethical dilemma. This is to better understand the reasoning behind the decision to place a loved one as a full code. Expressing grief is normal and every person can deal with it in a very different way. There's a process to grief. Kubler-Ross designed a model to help us understand this process. The first stage is denial. This stage is kind of like a state of shock. The news has been received that a loved one is nearing the end of life. The decision maker feels that life is about to change forever, and their initial decision is to stop that from happening. Anger is the second stage of the grieving process. Here is where the decision maker is very upset and doesn't understand why this must happen to them. They feel angry, and this is a natural step in the process. The next step is called bargaining. Many individuals will plead and beg for God to heal their loved one. They may say, "If you heal my mother, I promise to be the best daughter that I can be." This is also a lot of times where guilt comes into play. If I would have only taken better care of her, this wouldn't be happening. Depression is the next step and probably takes the longest to deal with. This is a present emotion. Individuals may feel empty, numb, withdrawn, and not have the motivation to even get out of bed. After the depression phase passes, acceptance is the last step. This doesn't mean the individual is happy or that it makes things better. It simply means that they have accepted the outcome and feel that they will be okay to get through it. Throughout this process, there will be crying, difficulty sleeping, frustration, anger, guilt, feelings of hopelessness, loss of appetite, and anxiety. Counseling can be helpful and is a solid approach to help with grief, and it's highly recommended. It's hard to understand why someone would let their loved one suffer through the effects of CPR. I know it isn't thought of the same way by everyone. However, there is sufficient evidence showing that resuscitation isn't always the answer. I feel there should be more education on what resuscitation and other life-saving measures include and the effects that it has on the body. Doing compressions can cause fractures to the ribs and sternum, which the elderly is already at increased risk for. The lungs can also collapse, which causes further damage and requires more extensive treatment. If the patient is revived, he or she will probably be intubated and placed on a ventilator, and there is a small chance of them ever coming off of it. Intubation is the process in which a tube is placed down the throat into the trachea. It's then attached to a ventilator that breathes for the patient. This is very uncomfortable, and the patient is usually sedated with strong IV medications, and the patient may also be restrained to prevent them from pulling out the tube. If the patient needs to be ventilated for more than a few days, the doctor may suggest a tracheotomy. This is a surgical procedure and is basically a hole in the throat where a tube can be placed. This also carries risks such as infection, bleeding, or collapsed lungs. Less than 12% of patients 90 and older survive and discharge from the hospital. Those who survive are normally left with functional deficits and their quality of life is drastically decreased. It's very important that families and physicians talk this out and come to a compromise for the best interest of the patient. I think it's also crucial that families talk it over amongst themselves and consider what the patient themselves would want. Would they want to spend their last minutes or days being in pain, uncomfortable, restless, and scared? Or would they want to spend it being surrounded by their loving family? My first real-life ethical dilemma in nursing relates to this very topic. I once took care of a female patient, 92 years of age, weighing 77 pounds. She stopped eating and started deteriorating. She had been diagnosed with dementia several years earlier, and the physician then determined she was no longer capacitated to make her own medical decisions. The physician spoke with her medical power of attorney and explained the situation and recommended a DNR order. The MPOA, who was a niece rather than a child, refused to sign a DNR and stated that she felt there were more interventions that could be taken to prolong her life. This situation ended up going to the ethical board, where a judge determined the patient's quality of life was more important than the life-prolonging measures that the MPA was requesting. Since then, I have noticed so many more situations regarding this dilemma. I truly do think that if more patient education was done on this topic, it would be easier for patients and families to make an informative decision. The body goes through a natural process when death is occurring. Individuals sleep a lot more. The heart starts beating slower and with less force, which leads to slower circulation. Therefore, the brain and organs begin to receive less oxygen than they need. They become less social and their appetite is reduced. This can be where decision makers decide to insert a peg tube in their loved one, which is a tube placed into the stomach so the patient can be fed a formula filled with nutrients without physically eating. Family members feel that if their loved one can get all these extra nutrients, that it will prolong their life and possibly get them going again. Inserting a feeding tube in a patient who is recovering from illness can be very helpful, but at the end of life, a feeding tube can cause more discomfort and put the patient through unnecessary trauma. Tube feeding will not prolong life in patients with dementia or chronic terminal illness. Tube feeding also increases risk for aspiration in the elderly, which can result in pneumonia. At the end of life, loss of appetite is common and natural. It has been found that even if receiving enteral feedings through a feeding tube, the nutrients are simply not absorbed. When approaching end of life, hunger followed by thirst is lost first. This is due to the body's metabolism slowing down and them not using much energy. Therefore, the body needs less nutrition. Taste is also drastically decreased during elder years, and the saliva glands tend to slow down. This means food doesn't taste as good and is harder to digest. Hearing is usually the last thing to go. Physicians and other healthcare providers tend to tell families to still speak to their loved one because they can still hear as well as feel touch. Another common thing I've witnessed is labs and diagnostic testing. Some people choose to have every test in lab ran to see if there's anything that can be fixed. This makes sense if the physician suspects something that might be reversible. However, in our situation, a 96-year-old male, for example, who has stage dementia and a long extensive illness background, more than likely will put the patient through more pain and discomfort. If a patient is in renal failure, dialysis may be ordered, which can also be a painful ordeal as there must be a port inserted to receive dialysis. Dialysis uses what is called a hemodialyzer to remove waste and extra fluid from the blood. This acts as an artificial kidney. The blood is pumped through the dialyzer, which filters the waste and then returns it to the body. Dialysis also carries a number of risks, such as low blood pressure, muscle cramps, severe itching, insomnia, and anemia. Some people are concerned about pain during the dying process. While there is no clear-cut explanation for this, there have been some studies conducted trying to explain. Each cause of death involves different processes. Some people with chronic illness has built a tolerance to pain and some have not. No one wants to be in pain during their last days on earth, and this is another ethical dilemma in itself. I feel that one of the highest priorities during death should be to alleviate all pain. Physicians will usually prescribe pain medication, but if the nurse or family feels their loved one is still experiencing pain or discomfort, they can always request an increase or a different medication. There are physical changes that can also be seen very close to death. You may notice their eyes tear or have a glaze effect. Their pulse may be irregular or hard to feel. The body temperature drops and the extremities can become mottled. This means they can be a bluish purple color. Breathing is interrupted and the patient will begin to gasp until they stop breathing completely. When someone is nearing death or has a terminal illness, they have the option to receive palliative or hospice care. Hospice care focuses on caring and comfort, not curing. This type of care is designed to help with physical and emotional symptoms that cause pain, distress, and discomfort. It helps the patient to be as comfortable as possible and can help with tasks such as bathing and feeding. This service is usually offered to patients who have a life expectancy of less than 6 months. There's also support for the families during and after this time. Palliative care helps to improve the quality of life in patients who face life-threatening illness. This care focuses on the prevention and relief of suffering through early detection of pain and other problems. It's a support system to help patients live as actively as possible up until their death. In conclusion, my ethical dilemma paper focused on the end-of-life care one may receive. Everyone has different views and opinions on how they feel about dying and whether to make their loved one a DNR or full code. My opinion is this: I want my loved ones to live as long and as healthy as possible. However, when the time comes, I want them to feel as loved and as comfortable as they can during their last months or days here on earth. I would not want my elderly parents to suffer through pain and discomfort and the outcome be the same. This is not speaking for younger, healthy adults. I absolutely support CPR and life-saving measures 100% in someone who has a chance to survive and their quality of life not be altered drastically.